Welcome to this special webinar event, Complementary Technologies Used with Robotic-Assisted Bronchoscopy for the Evaluation of Peripheral Lung Nodules, sponsored by Mauna Kea Technologies, the creators of Cellvizio. Before we all get started, please note that you all have joined in a listen-only mode. You may ask questions using the question feature, which is located on your control panel. We will try to address questions as they come in, and if not, we will try to address them at the end of the presentation. Tonight's speakers, we have Drs. Chris Manley, Brian Husta, Kyle Hogarth, and Omar Ibrahim. At this time, I'm going to hand it over to Dr. Ibrahim to get us started.
I just want to say thank you very much for allowing me to talk, to be here with my colleagues to discuss peripheral lung nodule biopsy and the different technologies we have available. I didn't put a disclosure slide, but I do do some consulting for Oris Medical, so please keep that in mind as we go forward. So again, my name is Omar Ibrahim. I'm the Director of Interventional Pulmonary, Associate Professor at UConn Health. And so I was fortunate enough to acquire the Monarch technology approximately 3 years ago. We've done over 200 cases at this point, and over the last about 2 years, and now so more regularly, we've been adding cone beam CT with augmented fluoro. So I'm going to take a few slides here to kind of talk about the two technologies, how they work together, and then I'll pass it on to my colleagues. This is the first case. So this is a gentleman with a ground glass opacity, and we used augmented fluoro to confirm that we're in place, in the correct place. As you can see here, there's 2 CAT scan images, and we used the Monarch platform to get us as close as possible. Now, the airway actually was too narrow to enter with the scope. So what we did was, but the airway did curve into it. So we used augmented fluoro with the cone beam CT spin in order to identify the lesion to confirm that we were actually as close to it as possible. So as you can see here, we have the augmented fluoro with the overlay, and it allows us to get as into the lesion, and you can see a concentric view. And that's essentially how, using the two technologies, we're able to, actually 3 if you think about it, with a radial probe, able to confirm placement of where we were, ultimately made the diagnosis, the patient went on to treatment. Next slide. So here's a 60-year-old history of right upper lobe lung cancer, developed a new solid lesion in the left apex, and here's again 2 representation slides of the CAT scan. You can see approximately a little under a centimeter lesion with some ground glass around it. Next slide. And again, one more representation of it. And as we drove out, we were approximately 20 millimeters from the lesion. And we were able to actually confirm with, so when you're doing the cone beam CT, that's the augmented fluoro on the left. And then we spin the patient at the same time, and you can see the tool and lesion, and ultimately making the diagnosis. Next slide. So I think we missed one in the beginning, but essentially you guys get the point of actually having real-time image to confirm where you are. There's multiple reasons to do this. I guess, you know, if you don't have on-site or it's a difficult lesion, you know, potentially if you're it's more ground glass, those kinds of things really help. The fluoro and the augmented fluoro will help elevate whatever platform you're using. So
Omar, how often are you finding that the cone beam is definitively changing your trajectory when you're doing this? I mean, is it an every day, or is it just occasionally that it's nice, or is it also just oh, it's great to see that you're in there? In other words, you know, are you truly needing it every time? I mean, obviously you have it, so you're using it, and it's great.
I don't think I actually need it every time, to be honest with you. I have it, and I think I probably spin a little more just because in the event that it's a negative biopsy, it's nice to have that confirmation. I think our colleagues in radiology have that luxury of showing that image and a negative and it's negative, right? And everybody believes it a tumor board. So I think making sure you have some type of confirmation image other than, you know, unfortunately them taking your word for it that you were there. I think, you know, and we do ourselves a disservice as bronchoscopists because I think we all think we're hot shots in general. And I'll
Someone
pass.
also asked online if you always use Rebus. Omar, do you personally use Rebus every time?
For ground glass, if it's a pure ground glass lesion, I probably don't, and I'll rely more on the cone beam. I think the Rebus is really good if you have a solid component. You can sometimes make out a ground glass component, but it's pretty difficult for the most part. And if you put in some saline or something like that in the airway, you've kind of distorted it. And then also the Rebus will only go if there's an airway. So if you don't have an airway, then and you're just trying to go for something that's eccentric, you're not really going to see it. So, but
Right.
with that being said, the cone beam, I found myself now when I have cone beam, I use a needle a lot more than I did before, because now it's about the trajectory of my needle as opposed to an airway trying to get as close as possible. So I'd rather be further away, but have have my for lack of a better term, my crosshairs on the lesion and put my needle out and confirm with augmented fluoro and cone beam CT.
The proverbial alignment's more important than proximity.
Correct.
So I just thought Brian nod his head, so I'm assuming he just agreed.
We'll let Brian take over from here.
Good evening, everybody. Brian Husta from MSK. I'm one of the 9 doctors actually that do robotic assisted bronchoscopy here, a program of 5 interventional pulmonologists and 4 thoracic surgeons. I'd like to share our experience with the Siemens system, mobile cone beam, a lot of different terms that are used for similar systems, cone beam light. It is actually a cone beam CT scan, and allows you to get much more detailed images when doing these robotic assisted bronchoscopy cases. Next slide. I do give lectures for, I don't have a disclosure slide, but I do give lectures for ION. And here's a list of a few different similar platforms that can be used for obtaining images real time during your robotic bronchoscopy cases. As you can see them listed here. We were previously using the Medtronic ORM even with our EMN cases with superdimension previously, but have since moved on to the Siemens platform. Next slide. So you can see here dimensions are rather similar to a conventional C-arm. Of course, it acquires CT scan like images, but also in the same system, much like a fixed cone beam CT system, can acquire X-ray fluoroscopy images, 2-dimensional. Unfortunately, does not have the capability of augmented fluoroscopy, but of course you can combine it with other systems like radial EBUS. The image that you can view is about 16 by 16 by 16 centimeters in your field of view. The spin takes about 30 seconds, and it does require you to have a compatible bed. Next slide. One of the more common questions that I get is, what is the radiation dose that you get? One way to kind of level the playing field is by using this the value of effective dose, which is in millisieverts. And it depends, it's different based from patient to patient, because during fluoroscopy or during acquisition of these CT-like images, the radiation dose is adjusted based off the patient's density. So thicker patients will have higher radiation dose. So it's hard to compare these different systems using the doses that you get at the end of a case. Effective dose is really the best way to do it. The platforms will produce a number at the end of the spin that is in dose area products, which allows you to monitor the radiation dose and depends on the power that you use, but is variable. Next slide. You can see on this graph here with multi-slice CT and the teal colored here, the 1 year of natural radiation dose, and then in the orange on the right side here, you can see what cone beam CT radiation doses are like using that effective dose in millisieverts. You can see on the y-axis. So about 1 millisievert for a spin using one of the fixed cone beam systems. And depending on which setting you use on your mobile cone beam CT, rather low doses. Next. You can see here pretty low doses, 0.14 millisieverts, and depending if you use higher doses with more slides. Next slide. The dose area product comparison between a 3D spin and two-dimensional fluoro really depends on your setting of fluoro. But one way to think about it is that if you use a standard 30-second spin with 200 projections and you use fluoro at about 6.7 frames per second, some of us might use 15 or 30. But if you level the playing field there, you can pretty much assume that if powers and milliamp is about the same, one standard 30-second scan is roughly equivalent to 30 seconds of AP fluoro at 7 frames per second. You can see how that changes on the left. Next slide. This is what our room looks like. You can see the C arm on the left and the robot up on the down in the center. We bring the C arm over and make sure that in an AP, as well as the 90-degree projection, lateral projection, that the area that we want to image is in the center. And once we navigate out there, we'll perform a spin. Next slide. And if you can play this video, this is what it looks like. About 30 seconds spinning around the patient. You can see the needle is deployed. So we probably had a nice radial EVIS concentric view there, deployed the needle, did a spin. One thing to be mindful of is that you could get bleeding if you're deploying a needle, of course, and might obscure your target. So you want to at least have one other confirmatory tool showing that you were there before you do that. But one way to get around that is to do imaging with the radial EVIS probe out. Next slide. And you can see what this looks like if you could play this video. Radial EVIS is deployed here. This is one of my partner's cases down close to the diaphragm. You can see the radial EVIS is just medial to the center of that target. We make some adjustments then based off of the distance that we see. You can make measurements and figure out how many millimeters in which direction, which plane you need to move. Next slide. And you can make those adjustments here. If you can press play, you can see that we have an eccentric view on radial EVIS. And we make a lateral move here using live two-dimensional fluoro. We can use our fluoro overlay, which is one of the options with the Ion robot. We can see that we actually made that change that we intended to make. So we can see we moved lateral a few millimeters. Next slide. And you can see pretty nicely here that we moved a little bit more lateral. We did our needle passes. You can see that in the screen on the right. Next slide. That's it.
Thanks, Brian.
So can I ask Omar and Brian then, Omar, Brian, I mean, I guess you demonstrated obviously the equivalent of tool and lesion, but there's no augmented fluoro. And Omar, obviously your combing system has the ability to do both. Do you find that you use augmented fluoro more or the confirmatory tool? And then I guess the converse, Brian, how often is it very obvious exactly what plane you need to shift in? Or is there a little bit of this going on once you get that, one spin view? I mean, ultimately, obviously it's providing value, but do you have to, futz with it a little bit because you don't always necessarily know exactly what plane you're in? So I threw it out at both of you, but I'm just curious because this advanced imaging really adds, the capability potentially for augmented fluoro. And do we need that more than tool and lesion or both? And so there it is.
So actually the augmented fluoro that's probably the best tool. And I can, the spatial arrangement, it's a hard concept to get your head around sometimes, and especially when you're in the case, you're trying to figure out what's up, what's north, what's south, that kind of thing. But the augmented fluoro, essentially what I'll do is I'll look at 3 views. So when I'm comfortable with where my tool is, I do 2 obliques and then an AP. So by that, I'm kind of triangulating where my needle is, and then I'll do the spin, the confirmatory spin. But what Brian said, I'll echo, the more you're mucking around, the more, especially if you're going for a ground glass or small lesion, I have post-procedure biopsies, and it looks like a mess. So, you know, like when you're looking at, you know, I think I'm there, or I think I was there, as opposed to, you know, really making sure that your first tool is really on point. You know, with the bleeding, again, you know, using a small needle, there's minimal bleeding, but you kind of like, you want to make sure that you're there. And I think that's, again, knowing your trajectory and really leaning on your nav or your, you know, your shape sensing software to make sure the trajectory is really there. It's important. It's a valuable tool, and obviously your radial probe if you can, because the radial probe is ideal, but if you don't have an airway going to it, it sometimes will, you know, you're going to be off the mark, so to speak.
Brian, what do you think? Are you jealous of Omar's augmented fluoro?
A little bit, but I would say that it is also it's not exactly real time, right? I mean, but it's definitely a step in the right direction. Radial EVIS is not completely real time because you have to put your probe out there. It goes a different direction from what your needle might do. So it's not exactly confirmatory. And what you really want, and what we all want, is something that confirms lesion and tool, not just tool and lesion, right? Everyone, you know, that's something that's thrown around a lot. And sure, I can navigate and put the needle right there, and I can look at it, and in every plane I am dead center, but it is not on the slide. So, you know, that's where that gap is. And I think these tools really help with robotic bronchoscopy, having that precision out there, but it's not the ultimate you know, solution.
Right.
And when it comes to those changes that you have to make, you really have to know in three-dimensional space where you are, where the tip of your robotic catheter is, and what happens as you deploy your tool. What is your trajectory? Are you actually going to be going a few more millimeters lateral? Are you going more cephalad? It all changes throughout the entire deployment of your tool. So it is challenging.
Let me dive into my slides on needle-based confocal laser endomicroscopy, because I think it adds another piece of data to try and help with navigation. So confocal microscopy has been around for a long time, but this is the first time that it's been available with a small enough probe to fit through a biopsy needle. You can see at the top of the screen, this is the bronchus needle. It's an 18 gauge, which fits confocal fiber with about 10,000 light fibers. It pairs pretty nicely with the robotic bronchoscope because you've got additional stability. I found if you can get the needle into the lesion, it sort of tethers the fibers. You don't get a lot of motion artifact. So you could probably use it with or without robotic bronchoscopy. But if you add the stability of the robot, you know, once you get the needle out and the probe through, there's very little motion even through the respiratory cycle. You can see on the right side of the screen, this is the new tower, so pretty small footprint in the bronchoscopy suite. I know space is certainly a premium for us, as it is for a lot of people in their labs. We know that proximity to the lesion allows for better sampling. We know that we need to get a little bit of off axis when we're approaching the lesion. And I think we all sort of agree that there's two parts. There's navigation to the lesion and there's biopsy of the lesion. You know, the closer you can get, the better. There's a wider angle of articulation when you're 5 millimeters away from a nodule versus 25 millimeters away. That said, if you're so far up against an airway wall and you can't watch your needle penetrate, you don't know if you're just scaving off down an airway, your rapid onsite showing you benign bronchial cells and debris. If you need to do a transbronchial biopsy, especially when there's no endobronchial component of disease, you need to know that you, one, through the airway wall into lung parenchyma, and two, into the lesion to get a quality sample. Near miss of nodules is common. I think a lot of us are frustrated because we have a successful nav. Fluoro looks good. Our nav tells us we're within 20 millimeters of the lesion. Radial ultrasound shows us an eccentric picture, but from there, the biopsy procedure can be extremely frustrating. Confocal microscopy, as I mentioned, has been around for quite some time. In the probe-based format, it was better for diffuse lung diseases. You can see at the top of the screen healthy alveoli versus organizing pneumonia or fibrosis. The work by Dr. Yuke Enema and his team at the University of Amsterdam really propelled Confocal forward in the space for lung cancer. The initial work was done in central lung lesions. This is through an EUS needle. He was able to biopsy central lesions and show significant differences in the confocal picture. You can see here that the clustering of cells, what we would refer to as pleomorphic or different sizes of the cells, and then sometimes, especially in the lymph node architecture, we have what's called directional streaming. As you go through different parts of the airway wall, lung parenchyma, and lesion, you can see that it looks quite different. In the pictures at the top of the screen, the lung nodule, it shows clusters of squamous cell or adenocarcinoma cells, and then that background is normal lung. You know, the normal lung parenchyma, as is shown in the cytology slides, the lung parenchyma is a much smaller size. The cells are much more uniform and very different from the clumping. As we do these procedures more and more with robotic bronchoscopy, we know that we get good stability from our combination of sheath and scope. But what we've done now is we infused 2.5 mLs of 10% fluorescein to give us some background contrast. And then we introduced a needle with the confocal probe. If we don't get lesional tissue, we make small micro adjustments in our robot and reintroduce the needle with the probe. We can fan through lesions, and also because the probe projects about 150 microns, the depth of field is fairly short, so you can go forward to back, scanning through the lesion. I found this very helpful because I've gotten to recognize what normal airway looks like, which has sort of striated smooth muscle. And then as you puncture through the normal airway, you can see lung parenchyma. So it really helps not just in localization of the nodule, but actually in more specific and more consistent needle placement. I think when we discuss these modalities, we talk about how to move a probe or a needle into the center of a three-dimensional target. As Brian mentioned, you could put it in the center of the target and not get tumor cells on your slide. That might be adequate for turning on an ablation catheter, which is going to destroy something based on its geometry. But when we're talking about drug delivery, we really want drug to be in contact with tumor cells. And so I think that this confocal microscope allows us to know when we're through the airway wall, into parenchyma, into the lesion, and then we could remove the confocal probe from inside the needle. And without changing the needle's position, so it really is a real-time modality, we could do our infusion, we could do our biopsy samples, what have you. I'll give you a very, very quick case. This is just a 64-year-old male with a new diagnosis of colon cancer. This was a locally advanced disease, stage 3C. Workup included a PET scan, which showed this PET avid nodule. He was a boat worker in China, pretty minimal smoking history. They asked us to rule in or rule out metastatic disease. When I approached the lesion, you can see that there's a lot of anthracotic pigment. We're in the proximal airway, we're proximal to the actual infiltrate, but you can see there's this very firm studding in the airway wall. It was difficult to scrape off, difficult to brush, difficult to get bites of, but we probed through. You can see the robot just proximal to the lesion. Confocal gives us an eccentric view of things, and then I was able to place my needle and do my confocal imaging. The confocal imaging showed, as you see here, this striated tissue, this dense, dark tissue. The white is the fluorescein contrast background, and then these clusters of very large, dense cells. Without moving the robot, I took needle biopsies and then did transbronchial biopsies. The needle biopsies yielded very little tissue, but the transbronchial showed granulomatous disease. With a positive quantiferon gold, we determined this patient actually had tuberculosis, and he started on treatment prior to chemotherapy for his locally advanced disease. I think in these situations, it could be very difficult if you were to start someone on immune suppression with latent TB and get reactivation tuberculosis. So this modality, I think, is helpful for both ruling in and ruling out cancer cells. Any questions so far, guys?
Chris, real quick, when did you infuse the fluorescein and how long does it last?
Yeah, it's a good question. So we actually get basically up to the nodule's front door, and right before I put in the needle, I give the fluorescein. Fluorescein can last up to 30 or 40 minutes, but the signal's best in the first probably 15 to 30. So you can give an additional dose. It's pretty well tolerated. But the nice thing about it is it's a small infusion, just 2.5 cc's, which I push through an IV. So you can control when it's given and you can control when you do the imaging.
Someone on the internet asked, I mean, with due respect to the case, don't you think you would have just gotten that answer with just some blind transbronchial biopsies? I mean, not blind, you navigated out with the robot. What did the confocal really add?
That's a good question. I think with all of these modalities, we're experimenting with how to employ them. And at this point, with my early experience, it's more proof of concept to me than anything else. I want to see multiple redundant pieces of data that are showing me that I'm in the right place. Now, this was a large, fairly large PET avid infiltrate. I could have done blind biopsies, but you saw that there was these endobronchial studding, and given it was granulomatous disease, it's very difficult to get adequate needle biopsies. But to see what the needle saw, to see that there was this granulomatous signal when you put your needle into a very firm lesion, it goes a long way to prove proof of concept that you can get a needle into a lesion and not get lesion into your needle, right? And so by extension, if we're going after small 8 millimeter, cancerous lesions, and you're poking around at them and carcinoid tumor or renal cell carcinoma, sarcoma, some of these very vascular lesions, filling your needle with blood, your slides are blood, they're non-diagnostic, extremely frustrating. But if you're able to image them, one, you don't displace the needle by passively putting an image probe against it. And two, if it's a very vascular lesion that's not going to give you the answer by needle biopsy, you can get a signal that gives you some information to suggest, one, you were in the lesion, and potentially how to act upon it.
Chris, do you take when you have the probe through your bronchus needle, which is obviously a very large needle, and you get confirmation, it looks visually to be consistent with malignant, is that then you don't move and that's the needle, you remove the probe and biopsy with that 18 gauge? And the only reason I bring that up is obviously Brian and Omar have talked about, from their imaging modalities, the complication of blood. And Omar's talking about using a small needle, and you're whipping out the old 18 gauger there. So I'm curious as to,
That's a great question. So I'll tell you that bronchus needle, it is large and it is fairly floppy. So the nice thing is the confocal acts as the stylet. But what I will say, if you can get the 18 gauge through the airway wall without difficulty, and you're getting good images, your needle's in good position. Sometimes once you take the stylet out, if you bring the needle too far back with no stylet, it's hard to get it back through the airway wall. So then you'll see it on fluoro being deflected. Sometimes I'll do additional biopsies with the 21 gauge Olympus needle I like a lot. And sometimes I'll do transbronchial biopsies in addition. So there's no perfect needle. I think that the data we've seen on EBUS needles comparing 19 and 21 and 22, I'm not sure that you're getting necessarily a better specimen with a larger needle, but I certainly don't think you're getting a worse one per se. I think that if you can have a long throw to your needle so you can leave the airway and get deep into the parenchyma, that's probably at this point the most important thing for me in terms of the qualities I look for.
Well, last thing, you obviously showed still images, but what you're getting is actually video, and things are moving. And you're right, some of the early experience with Mauna Kea had been with the non-locked in probe in the sense of down a needle. And there were, to be blunt, there were times where this was a Rorschach test of, you hope that maybe you're squint enough and you'll see what you think you're hoping you want to see. And so, cherry-picked images aside, what has been your experience and your ability to sort of learn this new terminology of flowing cells and pleomorphic so that you in real time are having it provide value because you've learned what you're looking at? Because that had been one of the biggest problems for this technology's been around for a while, but it's been lacking a Pictionary, if you will.
Yeah, I think that there's got to be a big educational push with any new technology, but with this one especially, because we're not trained to be cytologists. I think that if you plant the probe, if you really make a nice puncture and plant it, it doesn't move very much.
Okay.
I think that you need to be very gentle. So what I do is I'll actually put a little bit of positive pressure on the probe, even when I'm holding it still, just so you get good apposition of the fiber against the airway. If you just put the probe in and leave it, throughout the respiratory cycle, some of the tissue is going to actually be moving away from you as the lung expands. So you're going to get some motion artifact just through respiratory expansion. So you want to do a little bit of positive pressure so that at least as the lung starts moving in and out, away from the needle tip and back towards it, you have apposition. I think the second thing is any air bubbles that get in front can be very frustrating. So you really want to have the probe, we can flush the needle with saline before introducing the probe, and then not doing a lot of agitation. So if you place the needle and then start agitating it like you're doing biopsies, if you move it too quickly, you'll start getting air kind of moving along the tract of the needle. And that's a big, the air bubbles are very big, they have a very dark sort of circle surrounding them, and it can make interpretation difficult. So you need to be sort of mindful on your needle placement. You need to put a little positive pressure. You don't want to move it too much. 150 microns is a very small depth of penetration, so small movements translate to large movements on your screen. And then you need patience with training, because it is something new. It's like when we started training with chest ultrasound or EBUS, someone brand new, a med student or visitor comes into your bronch suite, they can't tell 4R from 4L, but you can see it very easily, even on a, as you say, cherry-picked still image. So I think there's a lot that needs to go to showing proof of concept and building out a platform that's truly additive to the space.
Seems like a machine learning algorithm and AI pattern recognition would be real beneficial here.
Yeah, absolutely.
All right, I'm going to add to it. Do you want to? Are you going to advance my slides for me, Chris?
Happy to.
Thanks, dude. All right, case one. So we're just going to talk about my experience. I'm going to highlight 2 cases of the Cellvizio platform, and then also talk about another fluoroscopic platform. So 69, as you can see, had a right lower lobe nodule, interval increased, but the PET scan was negative. And despite the negative PET, the concern was still high enough given growth and risk factors, and the patient wanted to pursue a tissue diagnosis, partly also based on the size of the lesion. So next slide. If you don't mind just playing the movie real quick, we'll see the lesion. There it is. Okay, next. I'm going to try to be quick. So all this was showing was, this is first a Rebus view, a split between these airways, and really trying to get a good sense of where's our best targeting approach. So there's right now the only imaging modality is just radial probe, and then obviously the targeting component of the Monarch, and similar to any navigation platform you'd be using in the periphery as far as targeting. All right, next slide. Then this is my view of the 19 gauge or 18 gauge, excuse me, bronchus needle. We had obviously discovered that the airway on the right was the slightly better approach coming into the side. This is the Mauna Kea probe going out. That's why everything's kind of holding still. You don't see me jabbing anything yet. Next slide. And we got this. Play this movie, Chris. Chris, tell everyone what we're seeing here.
Yeah, so the white fluorescent is the contrast, and you see some clumping of cells. The cells are all fairly similar size. There's definitely some dark clustering, but not totally bizarre. I think that, it's hard to, at least at my level of learning, to say that this is definitely malignant, definitely benign. I think that you're through the airway wall and into the lung parenchyma, and you've got some dense clustering of some kind of cells, but I couldn't tell you tumor cells or non-tumor cells.
So as we were doing this case, the folks from Mauna Kea are there who obviously have a lot of experience looking at these, and they were highlighting that the cells have that like a streaming effect, in the sense of they're the darker cells. They're clearly not normal airway cells from their perspective, and that this clustering of these darker cells that sort of feel like they're flowing across the screen a little bit was consistent. And I think, this is both, I think, where my interest lies, but also where my criticism, and to the folks from Mauna Kea's credit, they sponsored this program, but they also said that we didn't have to be nice. And so, but I think there's a lot of potential here. I'm glad that they're spending time letting us learn and working through this, because there have been a couple of questions that have come in that we'll get to when I go on with my presentation. Go ahead and hit it, Chris.
So, one thing I want to point out is that at the bottom of this screen, you can actually see a little capillary that's pulsing through there. You see right about a third of the way up, it's going from left to right. And every time the patient kind of breathes out, you see some squeaky cells slide past. Yep, yeah, right there. And so
Cool.
The other thing I want to point out is, you can see a little bit of motion through the respiratory cycle, but you're not, these cells are not flying from one side of the screen to the other. So, the point in my,
and you're right, that is different when I had used it in a decade ago in lung, and that's because the needle's obviously embedded through the wall and in the lesion.
exactly.
All right, go on to the next slide. That's a nice thing to point out, Chris. So this was one of the single greatest things I would suggest anyone invest in their bronch suite is the digital microscope, so you can fight with your cytopathologist when they try to tell you you're non-diagnostic, because I can see cancer cells too. And so this was the biopsy passes that correlated with obviously that. So it was an adenocarcinoma. Next slide.
I'm sorry, everyone.
Yeah, no, my staff always comes in too, Chris. All right. Hey, your nurse is really young, dude. So then we've got this person now. Right lower lobe nodule, 7 millimeters, showed an interval crease to 9 with negative PET, still smoking, but cut way down. Now, this is somebody who everyone had said, we should not really be doing anything. And the patient didn't want to have anything done from a surgical perspective, but absolutely wanted a biopsy. So I was pushing to not do anything, and I got essentially pushed to go bronch this person. Next slide. Here's this lesion. Okay, next slide. This video gets long, so we're gonna just skip this. We navigated down to it. I think, but we got this nice radial eccentric view, which obviously helped from a perspective of seeing what the video showed you. You can obviously see which wall the radial probe's on, so that obviously then you know where to angle your needle. Next slide. And so that's what you'll see here. Go ahead and play this video for a little bit. I tried to trim them down, but there it comes. So we move and obviously position the robot, get the needle onto the wall that we had affirmed was where the eccentric view was consistent with, and jab through, and then we get our Mauna Kea view. So let's go on to the next. So the first two passes.
Those are air bubbles, right, Kyle? You see those black, very dark ring, very, very round.
I lost you, Chris.
Yeah.
So with the first two needle passes, when we passed the needle in, and the video's going, this is the final video, but we just saw a bunch of air and then bronchus cells and macrophages. So we made some minor adjustments, similar to what Chris had talked about, and just angled the needle a little bit more, knowing obviously we were eccentric. We think probably in retrospect we were coming in a little shallow, and so we went in a little more deep. And now we start to see there's these cells. Now those are very different than the air bubbles that we were seeing earlier. And the third pass was become more consistent visually from Mauna Kea as malignancy. So you can see these outlined air bubbles that Chris had highlighted before. And then next slide. And then this was again cancer. So negative PET, slight growth, but tagged with a fiducial and going to go for resection. Obviously, or someday maybe ablate, right? So I think, you know, I'm still in my mind, we've been using this technology and adding it into our repertoire. I think I feel similar to Chris in that other things that, you know, can add to my confidence of tool and lesion, whether that's cone beam and blah 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 and rebus and this. Ultimately, of course, what I care about is what we all care about. I got to see this on the screen, you know, big cells that someone's going to for sure call cancer. But I think we need to keep working on getting a better understanding of what we're seeing with confocal. So next slide, I want to introduce some other technologies. One other technology. Let's talk about LungVision quick. So CT to body divergence is always an issue. Obviously, I think that's one of the where Omar's talked about augmented fluoro, being able to real-time image where the lesion is, and Brian talked about also being able to see it. And you know, both robotic platforms obviously are all based off of a pre-planning CT, and there is CT to body divergence for many different reasons. And updating the lesion in real time is one of the key things about real-time imaging. Next slide. So the LungVision platform uses a C-arm to, and it's a simple box that takes in multiple pieces of data. Next slide. One of the reasons we looked at it, so I'm going to talk about real-time TOMO integration between LungVision and the Monarch. Next slide. Is, you know, we can't all be Omar and have someone buy us a multi-million-dollar device. Actually, there was a question coming in as to how you got your cone beam. And, you know, Brian with his 30 colleagues probably just snaps his fingers and gets another C-arm. But some of us work in some poor hospitals. And so I'm kidding. University of Chicago buys me crap too. But anyway, so let's talk about using real-time TOMO. 64-year-old history of colon cancer, resected and cured. Got a complex renal cyst that's concerning for renal cell, just generically. And then he's found to have a nodule during this workup. And he's got PET positivity across his prior colon resection, but was negative on a colonoscopy. So he's got the whole, what's the 8mm thing? Next slide. Usual plan, it's got an 8mm lesion, but there's no direct airway going into it, and it's bracketed by 2 blood vessels. Next slide. So when we get out to the lesion and we put our radial probe out or a needle out, this is the image you get. Go ahead and play the movie. This is the image you get when you do the, it's a negative 50 to 40 essentially, and you highlight the lesion on the LungVision system, and obviously have your equivalent correlate from the pre-planned CT. Next slide. And then during fluoro, go ahead and play that for me. You can obviously see the robotic system. The first overlays you're seeing are just airway overlays, but the little yellow ball represents the real-time confirmation, obviously from TOMO. This is where your lesion is. Now, obviously, this is a fluoroscopically invisible lesion, but the augmented fluoro here is obviously then proof that my tool, and the video jumps, I chopped it, but the tool is truly inside the lesion, and I know that yellow ball represents the lesion. And sorry, but I failed on the video recording to give you the other views, but much like Omar talked about, and I'm sure Brian does as well, you get confirmation across multiple planes that you're there. Next slide. And this ended up being metastatic renal cell. Next slide. So again, the idea of confirmation of a tool and lesion, hit it again. Hit the video for me, Chris. Thanks, bud. So you see the TOMO spin, and this is just, and this works with any C-arm. This actually works with the CO spin as well too, Brian. You can obviously mark your lesion and then see that your CT correlate and do it across a couple planes. Next slide. And it takes about a minute to process this. Next slide. And then obviously you can see there in this video our robot in front of the lesion, and then ultimately go ahead and play this one. You see here under fluoro, our lesion. Now you'll notice right now the lesion's not moving with respiration, and that's because the machine learning algorithm right now does not recognize anything other than their own proprietary catheter. But we're doing a project right now to get a stylus that down the Monarch that their system is able to recognize. And what would be the purpose of that? So go on to the next slide. And that was an ad note. Go on to the next slide because I want to show you where this really is going. Because the AI hasn't been trained across the Monarch or Superdimension or the Ion, but their catheter, you can get some really fantastic views. But the catheter is a blind catheter, and so I'm not going to use it. So what's coming, next slide, is this. And so this is go ahead and play the video. So this is imaging that I get from using my C-arm, utilizing their catheter. So that there's the representation of their catheter. But that catheter now is a stylus that we're training the AI on my robot, so that we'll get views like this with the Monarch and presumably with the Ion, etc., by using their stylus down the working channel of your scope, so that you can get cone beam quality images while still getting your augmented fluoro. So this is a tool that we've been exploring more and more and combining it. Next slide. And tonight the Blackhawks have their start of their season. Go Hawks.
Kyle, can you talk to us a little bit about how it worked into your workflow with Tomo?
Yeah. So at the beginning of a case, anesthesia knocks them out, get them all set up, blah, blah, blah. Before we even go in and do an inspection bronch, we have to take 3 snapshots, LAO, AP, and RAO to give the rib borders out. Then you do that Tomo spin of essentially 50 to 40. You can do less if you have bed restrictions around the main carina, something that's essentially not going to move. And now you're registered. And so while that's processing, we go in with the standard scope, suck out, airway inspect. Then we isocenter around the lesion. The pre-planning CT knew where the lesion was, and now we do a breath hold spin around the lesion. And then while that's processing, we start to set up the robot, and I walk over and then outline where the fluoro is. Move the C-arm the heck out of the way, navigate like you would, again, whatever platform you're using, navigate out, and then when you come in, if you bring fluoro in and you step on the fluoro, you get this automatic overlay. And what's been fascinating, and I know people that have who are using this system with the Ion have said the same thing. So it's not a robot thing. There's the pre-planning location of the lesion, and as we all know, CT to body divergence. And then inevitably, as you then click on the updated location because you've used Tomo, you see it shift. And obviously, depending on the lesion's location, the lesion size, you may see it shift a little, see it shift a lot. What is then obviously similar to what I think Brian was describing with using the CEOs, and I know Omar does too, we will make adjustments with the Monarch to get the tip of the lesion or the tip of the needle or whatever tool we're using to line up then on multiple planes with fluoro. This has mattered more and more when we're going after smaller lesions. Clearly, like a 2-centimeter lesion, even a CT to body divergence of a centimeter doesn't matter. You're going to hit the thing eventually, right? But tiny little things, having that level of precision really matters or does matter. And then I think where that's helped us as well is then the needles allowed us to make a hole in the airway to get then forceps easily into the lesion through the hole. We had a case of that last week, and so we were able to get even bigger samples and without having to actually tear apart part of the airway by just leaving the needle hole in the airway.
I was surprised looking at all of these images and previous ones that have been shared about just how quickly atelectasis sets in. I think Mike Pritchett's paper on some of the anesthesia concerns was a really nice review, and there was an article, he might have even referenced it in that paper, that they just compared pre-oxygenating at 100% FiO2 versus 80 versus 60, and found that if you're not pre-oxygenating at 100% FiO2, you preserve some of that nitrogen and you just prevent some of that atelectasis. And so I've been making some small changes, even not using a spin or a 3-dimensional imaging platform, but just trying to reduce that CT to body divergence by reducing atelectasis at the start of the case. And I've actually found my nav is working a little bit better.
Yeah, we've employed the Pinehurst protocol for anesthesia that makes navigation easier. If nothing else, the airways are popped open a little bit further anyway, but you're also minimizing CT to body divergence simply because you're getting that patient closer to the TLC they were at for the CT.
Right.
So in the interest of time, because we've got about roughly 7 minutes, I'm curious, and questions have come in about not cost of the devices, because everyone knows there's always a capital cost. It's the compounded extra time involved and or cost of, the use of the cone beam and the use of my fluoro and, another needle, Chris, and the probe from Mauna Kea, et cetera. At
Right.
some point, is our repetitive redundancies of confirmation, starting to eat into any theoretical profit. Granted, in bronchoscopy, that means the difference between getting the venti or the grande when you go to Starbucks the next morning. But when we start talking profit in bronchoscopy, but just curious, anybody?
Yeah, I'll tell you that we're definitely cognizant of the cost of the devices. I think that, we would all love cone beam CTs, fixed units and large labs and everything. And short of that, we're trying to crack the code, as is everyone else. I think that probably some of it will depend on your style and what devices you employ, but I do think that they will consolidate around one or two technologies in the space, whether it's something proprietary or something that ends up standard on all C-arms as they come out. I just think it's too soon to say.
I would say it has something to do with what you're trying to achieve for your own program, right? I don't think everyone needs to have a fixed cone beam CT and a robot and a confocal. It depends on what you're trying to add to your practice. If, for us, we're biopsying multiple nodules, patients with multiple different cancers, it makes sense to go after these nodules and take a longer, have a longer procedure, but you get the answer for the patient. So that's the difference for our specific practice and why it makes sense to have some of these additional tools. And even though they're more expensive and the procedure, definitely if you go after a more challenging nodule, it's going to be a longer procedure. There's no way around that. But you're justifying that by getting the patient the answer, whereas other types of biopsies may have not been feasible. The patient declines it, but you get them the answer the way that they wanted to get it. So I think that's one thing to consider.
That's what matters in the end, right? I didn't mean to interrupt you, Omar, but like your patient really doesn't care whether you used one technology or 9. They just want a diagnosis.
Yeah, no, I agree with that. Going on and, joking about like having a cone beam and a robot, and yeah, I'm fortunate to have that. But that being said, I think that, I think we've talked about this in the past. You have to realize where you're at, as Brian was saying, and what your institution can offer. So I got access to the cone beam because, so we have an IR suite, we have cardiology has their own suite, and we have a very active neurosurgeon who, who uses predominantly the hybrid room with the vascular surgeon, but they don't have cases booked every day solid. So I found out what day they didn't have block time in that room. We have staff in the room available because we are a stroke hospital, so we have to have staff there. So I just moved my procedures to that day without increasing the overhead because we were paying staff to be here anyway. Now, if there's a stroke, I get kicked out of the room. So be it. It happens. So it's finding those ways of nuances to actually say, oh, I'm actually saving you money because now you can allocate staff to do something else because we're paying the staff to be there anyway. So and it's also knowing what you have, right? I think that GI might have some of these tools in their area, but they're not using it, or they use it every so often. So be aware, like go poke around in other parts of the hospital you don't normally go to see what's available.
Yeah, my Cellvizio system is owned by GI, and so we just steal it from them. Never mind, completely forgot my question. Someone else say something. Activate the stroke code. No other questions have come in essentially from the internet, but I think I'll say for everybody, I think a nice discussion. Oh, and now I remember my question. So this is the other importance, or I think a lot of these technologies have added on. People talk about ablation from a therapeutics perspective, but long before I think we're going to see ablation, there's several trials that we're already a part of at our own institution, and I'm sure others on the call are, and I know you guys are. We're injecting multiple different things into tumors that are all some various clinical study, but that all require the ability to confirm that you are definitively in the lesion, to definitively inject. One's a virus, another's a nanoparticle, another one's a radioactive. I mean, the list goes on and on and on and on. And I think what's interesting about some of these platforms is the opportunity it's opening up for all of us to give multiple different therapeutic interventions, not just the thought process of an ablative curative intent, but also even in, a phenomenon. We're doing this one where the tumor is basically getting infected with herpes, and they take Valtrex and they get an abscopal-like effect, right? And this is so it's metastatic disease, but we're injecting into the direct tumor. But you need a robot. At least by the trial you do. The trial requires it.
So, going to what you're saying about, these therapeutic trials, and I think it's important that we do have confirmation just to know that we're in the lesion for the trials. But I think for a lot of these things, it'll almost be like horseshoes, right? We got to be close enough as opposed to direct center. But I think if we can't prove the concept being directly in the lesion, it's a hard sell, right? It's a hard sell because then you're just going to have people doing BALs, injecting chemo, with the BAL, right? Because, I got close enough. So I think we got to prove concept first, and then eventually move on. And the goal is to make it applicable to everybody, right? Like to do it with a small catheter that fits through a traditional bronchoscope or a disposable bronchoscope, because that would be ideal, right? But unfortunately, we're not there.
I think the only way that we get there is to generate experience with these diagnostic tools, right? I mean, the goal is always to get to treatment modalities, but Omar, from your experience, how many cone beam CTs does it take until you're comfortable using that room? You don't want to learn that while you're trying to ablate a lesion or inject a lesion. You need to develop a high degree of expertise with a variety of diagnostic modalities, and then find how it's iterative, and you add on the therapeutic pieces to the puzzle after you've gained a stepwise expertise. And I think that at this point in the space, avoiding the temptation to have kind of earth-shattering changes all at once, and exploring what each of these modalities can do is important.
Great conversation as always. Thanks for leading the charge, Chris.
Thanks all.
Thank you all.
Take care, guys. Good seeing everybody.
Have a good night.